Pepose. Jay, at this meeting and in meetings recently, generally, there's been a lot of interest, a lot of talk, conversation dealing with presbyopic um, um, intraocular lenses. Now, I say that in the plural, lenses, because there are multiple ways of managing this and multiple optical avenues for treating it. And anything that has got multiple treatments has multiple treatments because there's no one perfect one. Um, it, it, as a consumer, meaning as an ophthalmologist, not as a patient, it's very, very difficult because what I wind up doing is speaking to people who are working on a particular avenue, and there's no real comparison. It's very, very hard to get access to studies. There are studies that compare different ways of managing things, but that's exactly what you've done. So let me ask you to describe your study, and I can't wait to hear what you found.
Thanks, Josh. Well, what we did is we put together two studies, and each study looked at a different optical design of a lens. We had an accommodating lens, a crystal lens, bilateral. We had two light-splitting lenses, a Restore 3, a Technis 4 multifocal. And then we had a group of patients with a monofocal in one eye and a small aperture IOL called the IC8 in the contralateral eye.
That's the lens that sort of looks like a camera insert, but it's not at the cornea level, it's at the IOL level?
Correct. It's an acrylic lens, but embedded in the lens is a ring, an opaque ring with a 1.38 millimeter aperture, and basically it's blocking the unfocused light. The advantages, at least in studies outside of the U.S., of this type of lens design is it's very forgiving. It's good in patients with aberrated corneas. It's going to block a lot of unfocused light. It has a very broad landing platform. In other words, even plus or minus one, because it's really an EDOF
Yeah,
lens.
it's an extended depth
A
of
focus.
focus lens. Yeah.
Hmm. And it's another big advantage is without having to line up a toric, it's pretty much immune to up to about 1.5 diopters of corneal
Oh,
astigmatism.
that would make sense. That's interesting. So before we get to what your findings were, or even what your main outcome measures were, which should really be what the first question is, tell me what your anticipation or what your knowledge of the patient's experience is like with these three different lenses, because it's different. They're different.
Well, exactly. I mean, every time we're doing something that is not the natural way that we see when we're 20 years old, we've come up with these ingenious designs, but every design has an upside and a downside. With multifocals, we have an out of focus image superimposed on the retina at the same time, and for some people, that's going to create some haloing or some ghosting or some dysphotopsia. With a monofocal lens like an accommodating lens, if it truly accommodated 3 diopters, we'd be in good shape. But with 1 diopter, really, it's really an EDOF lens, right? We're going to get good intermediate vision, good distance vision. We may not have as much problems with glare or dysphotopsia, but we're not getting that full defocus curve. So you're exactly right. Um, so we were very interested to see not only what was the contrast sensitivity and the defocus curves, but also what are the complaints with each of these lenses.
Right. So, having said that, when you set up your studies, what were the sort of outcome measures that you used?
Well, exactly. We did do a defocus curve, meaning, we're measuring the patient's vision at different vergences,
Sure.
right? So we're seeing distance, intermediate, near. Also, when you look at a defocus curve, it also gives us certain strategies of how to best use the lens. For example, let's say we have an EDOF lens where if we targeted emetropia, we would get, let's say, 4 diopters of continuous vision, basically at least at a 20/30 level or greater. But we notice if we targeted minus 0.75, we only lost a few letters of distance, but we're gaining much more defocus. So now we've extended the depth of focus. So, for example, with the IC8, the new recommendation is to target minus 0.75 because the other eye is a monofocal, it can be targeted for distance, and that tiny difference It's not like monovision or even mini monovision
Right.
because you're blocking the unfocused light, so there's no loss of stereopsis, but you're gaining, you get 4.5 diopters of continuous range of vision, which is pretty dramatic.
That's really neat. I'm interrupting you. I'm sorry for that. That to me, as an optics geek, that makes sense because with a diffractive EDOF lens, the extended depth of focus extends near from whatever the refractive target is. But with a small aperture lens, it extends to both sides of it, and aiming for a little bit more myopic target. Well, that's not even fair to call it a myopic target, but you get that spread that extends both ways. Yeah.
Exactly, and now you're utilizing the entire defocus curve.
Yeah, really, really interesting. What did you find?
Well, what we found is, the crystal lens and the IC8 contralateral design was best for intermediate vision and very good distance vision. Hardly any ghosting complaints, and also very low halos compared to the multifocals. However, the multifocals were better for reading. I mean, there's no question that they had more near vision. So multifocals, the curve is not continuous, so they're intermediate, not quite as good as the EDOF lenses, but you're really getting very little dysphotopsia. And, so I think this is going to be a great lens, particularly for patients who have aberrated corneas. It could be good for an RK patient. It could be maybe a patient had LASIK where they were already complaining of some ghosting. Um, I think the fact that the downside is so low and you're blocking so much unfocused light, I think it's going to be very good lens for those kind of patients, and also patients who really, in a sense, want monovision effect, but they don't want the loss of stereopsis. And they're really, there's some patients who, if you talk to them and say, okay, here's a lens, but there could be some degree of haloing, and you'll probably adapt to it. But for some, that's a deal breaker. They said, no, that's why I'm having surgery. I'm
Yeah.
having halos at night. I don't, if that occurred, I would be disappointed. So this is a lens where I think we could offer as a premium type of lens, but because we're going to get extended depth of focus, but we're not going to have some of the downsides.
Really, really, really interesting stuff. Um, one last question, right? Um, Granted, when a patient comes in and you get a better understanding of their clinical context, you can have an idea about what lens would be optimized for them. Do you discuss all options with them? And if you do so, how do you limit chair time?
Well, I've done a couple of things. First of all, I have actually videotaped myself. I've had myself videotaped where I'm basically doing a consultation.
This is actually a great idea.
And what I tell the patient is, we're going to take, if you choose to do this, we're taking a journey, and the journey may have several steps to get to the end. We're going to be implanting a lens, which we're going to discuss. You may need a YAG capsulotomy. You might need a laser vision enhancement, and you may need time. 4 steps of the journey. And what happens is most patients don't need all 4 steps, but they're thinking, I need 4 steps on the front end. And so they're delighted if they don't need 4, but if they do, they remember that they were told that they saw the video. And that saves me a tremendous amount of chair time doing it in that way. Also, before I go in the room, I've looked at their biometry. If they have a big angle kappa, if they have very aberrated corneas, uh, I look at their pupil size. So I'm already making an assessment, even before I walk in the room, as to what lens, based on their biometry, I think would be
Yeah, of
compatible.
course, yeah.
And then I'm asking the patient, what's the most important, to you? Is it no haloing? Is it computer vision? And I think between the two, between the patient's history and the biometry, I think you can make a decision.
Oh, really, really, really interesting stuff. Because studies like this are so valuable uh, because as clinicians, the choices that we make are head-to-head choices, and single lens studies are just not that helpful for us. I want to thank you for bringing this really, really interesting, helpful, at least to my practice, info. And Jay, as always, I want to thank you for being so very generous with your time with us.
Oh, my pleasure. Thank you so much.